Good evening, ladies and gentlemen. Welcome to Current Approach Towards Patient Care through an Expert View during COVID-19. A program presented to you by Dr. Reddy's Laboratory, Sri Lanka. And it is my pleasure to welcome our moderator this evening, Dr. Dhammika Yatigammana, Medical Officer, National Hospital, Kandy, Sri Lanka. Dr. Yatigammana, over to you, sir.
Thank you very much, Anton. Of course, good evening, and we warmly welcome you to our webinar on current approach to patient care through expert view during COVID epidemic. Of course, this is presented by Dr. Reddy, and this evening we will be focusing on optimizing patient care during this COVID epidemic. Of course, for this purpose, we have a light panel of 3 speakers. They will look at this COVID epidemic through 3 different angles. Of course, let me introduce our first speaker, in the sense, our first expert, Dr. Harsha Sathischandra, consultant physician at National Hospital, Colombo, and welcome to the program, sir. And our next speaker is Dr. Aflah Sadikeen. He is a consultant respiratory physician attached to National Hospital, Colombo. And our third speaker is Dr. Chathurie Suraweera. She's a consultant psychiatrist attached to National Hospital, Colombo. And of course, she's a senior lecturer in psychiatry, Faculty of Medicine, Colombo. Of course, this program has 2 parts. First part will be individual discussions or presentations. The second part is questions and answers, where you can project or you can direct all your questions to our live panel of speakers. Then going back to our program, of course, emergence of COVID-19 or the coronavirus in Wuhan City, China was not a big issue for most of us during that time. In fact, being a distant place, and we knew that is something that has something to do with the Chinese eating pattern. We never thought that it will have a big health impact on global scenario. So we expected it to behave like another SARS or MERS infection that we experienced some time back. However, when it started spreading throughout the globe, say when it was going to neighboring countries like Japan and Korea, then it was spreading throughout Western Europe, then it was going to America. Of course, with the associated very high mortality statistics, we knew it's not going to be something like SARS or MERS, it's going to be something like Spanish flu, which killed more than 5 million in 1918. In fact, WHO declared it as a global emergency and a pandemic. And of course, when it came to Sri Lanka, our Sri Lankan health authorities were able to take appropriate measures. As a result, at a stage, we were in the verge of declaring the elimination or the declaration of eradication of the disease. However, with the emergence of some new cases in mid-April, we were forced to change our stance with the disease. In fact, now our approach is to live with the disease rather than eradication. In this context, of course, we hope it's timely to discuss and upgrade our audience, or mainly our audience, on various aspects of COVID management. With this purpose, we would like to start our discussion on updating knowledge in healthcare. Of course, I would like to start the discussion with Dr. Aflah Sadikeen, who is a consultant respiratory physician in Colombo National Hospital. Since these COVID patients are basically present to us with common respiratory symptoms. Dr. Aflah, how would you look at this whole scenario of COVID infection?
First of all, thank you very much. And Dr. Yatigammana, that's a great way to start our current burning question of what's the best approach we should put it forward when it comes to our patient care in this pandemic. Yes, now we see the number of new cases new COVID cases are going up in many parts of the world, and we see that in India as well, the numbers are going up, and also there's a number of deaths also going up. In Sri Lanka, yes, we thought things are under control, and that people thought the diagnosed and confirmed cases are just from 1 or 2 clusters, and many are asymptomatic or with mild symptoms, and most of them don't get very sick. However, we can't be complacent, because we can expect a second wave, and developing more and more clusters, and also a possible community spread in the future. So we saw that in South Korea as well. So now things are a little different. Why? Because there is a relaxation of the lockdown, which after nearly 2 months, and probably this is all to do with the socio-economic factors. However, with all these things, like I said before, we can't be complacent, and on the other hand, we have to strengthen our patient care when it comes for this panic mode, when it comes for this current epidemic. So to start with, I don't want to say that this is just a COVID epidemic. Why? Because I would like to call this as a global health pandemic. So when I say a global health pandemic, it's just the COVID pandemic is just one part. Why? Apart from this COVID pandemic, or this with the COVID, there is increased morbidity and mortality, and there's a lot of focus on its diagnosis. Start with prevention, then the diagnosis and the treatment, and there had been a lot of discussion going on all over the world. And to some extent, things are under control in many parts of the world, and still some are still struggling with in all that aspect. However, apart from this problem, or the first pandemic, or this first wave, I would say, there are 3 other waves where we are focused quite inappropriately, or I would say we have given less attention. So probably I would say these 3 waves are going to cause higher health impact. So when it comes for the care, when it comes to care for those the urgent conditions, we are finding, or we are seeing inadequate attention, or there is a restricted care for those patients. So especially the patients who are non-COVID respiratory condition coming to the primary care physicians, also to the healthcare institutions. Probably this is part of the panic or fear due to COVID itself, or maybe there is a restricted access and presentation by the patient themselves because of the fear of getting the disease from the healthcare institution. So what we need here is there's a big gap for those urgent intervention cases where you need urgent intervention to minimize the impact on those cases by giving less care. The third wave, or the third pandemic, I would say, is this neglected or substandard care for those chronic conditions. So like ischemic heart disease, diabetes mellitus, all these conditions are given less importance nowadays, and we are going to see the real impact of this minimum care for these patients in the near future. And of course, we should not forget the psychological trauma and its impact on the health well-being, which is going to have a big impact. I'm sure we will be hearing more on these 2 issues as well. Right. So as we started, it's all about respiratory symptoms, and it's going to be a big toll on the primary care physicians, and also especially when the patients present with acute respiratory symptoms. And of course, we know the symptoms for COVID, that is fever, cough, sore throat, and shortness of breath. Of course, these symptoms are not going to be as straightforward as such when they present in the primary care setup. However, what we need here is a careful and thorough symptom analysis. Remember, these presentation or these symptoms are or may be the first presentation or the only presentation for an ongoing non-COVID respiratory illness, or probably an exacerbation of an previously diagnosed respiratory illness, like exacerbation of asthma, exacerbation of COPD. So it's going to be challenging, no doubt, because to differentiate when there are two conditions or two clinically distinct setup presenting with the same symptoms, where you are not going to, you're going to compromise on what is important in those non-COVID patients. So what we have to do here is a thorough history, and this history taking or clinical analysis should be incorporated into a current epidemiological data. So these current epidemiological data should be assessed on the local scenario where you are going to see. So when we come across these acute respiratory symptoms, what we have to look here is whether we are seeing this patient fitting into a suspected COVID case. So here we have to be very thorough with our clinical definitions. Of course, we have got a good set of, from the beginning, we were guided by the Ministry of Health as well as the epidemiology unit, and with the collaboration of Ceylon College of Physicians, we have set up a good guideline in every aspect, not only just managing COVID, also the starting from healthcare protection and the work base and the hospital preparedness and so on, even for primary healthcare givers, how they should be prepared and how they should work on the clinical scenario in a suspected case. So whatever it is going to be very challenging, because when the patient is presented, and it's always that suspicion, that panic mode is going to set into your treatment or to assessment of the patient. However, though it is very challenging, and we have to do our best to differentiate these two clinical scenarios, because sometimes in an acute setup, it's not possible to wait for 6 hours or 12 hours until you wait for the confirmatory RT-PCR. And also we see those first, especially in the acute setup, severe acute respiratory infection, which are non-COVID, are going to be a big toll on the acute medical setup, where if there is any compromise on the treatment, it's going to cause a big impact on the health system. And in addition to that, we see quite a lot of chronic respiratory diseases like asthma, COPD, even interstitial lung diseases coming with exacerbation, which is very similar. So in addition to your clinical assessment, also you need to have a investigative process which should not be compromised just because you have that panic mode set up in your higher centers for COVID. So, and also some of those one or two symptoms presentation can be a sinister pathology of a person, where you like a lung malignancy. In that setup, we may not be able to detect and start early treatment, which may be curative in some of the instances. However, so in an event of an exacerbation or acute medical presentation of respiratory or illness, we can't compromise on the emergency intervention, including some of those procedures which we are going to do may generate aerosol which can propagate the infection, like non-invasive ventilation or even sometimes the nebulization. So we have to take all the infection prevention control strategies, and also the right guideline which is set by the Ministry of Health to assess, to use the personal protective equipments when we manage those patients. Of course, there are burning questions when it comes to personal protective equipments and the availability, and we have got the correct guideline on that regard as well. So it is, when it comes to previously diagnosed cases of chronic respiratory illness like asthma, COPD, rather than waiting for these patients coming to your practice or to the healthcare setup, it is quite important to assess or to prevent these exacerbations. So probably in the primary care setup, assessing those patients on remote consultation would be something we have to think very seriously, because it's not this pandemic is not going to be over within 1 or 2 months, so it may last for 1 or 2 years. And also there are so many myths which carried by, especially when it comes to respiratory cases, where use of inhaled corticosteroid, using of prophylactic antibiotic, all those myths should be cleared with proper education. And also we have to have established communication with the patient. Probably this is a good opportunity for the primary health caregivers to have a good rapport with your patient, to educate them and to make sure there are no exacerbations or unwanted emergency visit of your diagnosed patients. And also it's important to introduce the self-medications, especially we know that when it comes to asthma management, we talk about asthma action plan, and self-medication should be promoted, and they should be basically should be in the written action plan. We should be put forward by educating the patient. However, we know that we don't want those patients to have regular visits to your clinic or to your health institution, which is unwanted, in the sense that if the patient is coming for any regular visits without any ongoing or active problems. So we have to keep those things also in mind when we talk about the management of those chronic respiratory disease. And I would like to emphasize that at this junction, we have to talk about reassurance and having a good communication with those patients who are coming to your health institution, or even coming sometime they can come to you maybe with a diagnosed case, or maybe with a chronic respiratory illness, mainly because of the anxiety. So we, by reassurance and good communication, of course, a good clinical assessment would give them get back to their day-to-day activity by not burdening the healthcare system. At last but not least, I would like to emphasize on TB, because tuberculosis infection we know that it has been a big problem in our setup, and we know and we have seen there's a surge, and especially these undiagnosed TB infections coming to the health institution, also the primary health caregivers. We have to keep that in mind. So we have come across many times, in fact personally I have come across many times, these patients are presented with severe acute respiratory infection to your emergency and ending up with intensive care unit, but there had been a lot of delay or concern of this COVID, though the assessment, clinical assessment, and the line of thinking of TB infection has not been there. In fact, the recent study has shown that they are expecting about 1.6 million new cases of TB worldwide in the next 1 year or so. So I think it's something we have to be very mindful that we should take all the precautions and healthcare expertise to diagnose these conditions and manage appropriately to reduce the morbidity and mortality.
Of course, if I take the salient point, of course, you stress the importance of a proper clinical examination and going back to basics, and the ability to use remote medicine or telemedicine as a tool, and to prevent most of the exacerbation and things rather than anticipating acute emergencies. Of course, and Dr. Aflah, you mentioned specifically that with the COVID epidemic, there's a chance of missing certain other conditions as well, isn't it? So with that in mind, of course, while thanking Dr. Aflah for his comprehensive detailed description of his COVID in his perspective, I would like to move towards our second speaker, Dr. Sathischandra. Of course, as Dr. Aflah mentioned, how can we detect that important cases? In fact, with more and more awareness towards COVID, as Dr. Aflah quite rightly mentioned, we can observe that certain important medical conditions we are missing. What would you advise, or what would you think the ways of preventing this problem?
Yeah, thank you very much, Dr. Yatigammana. I must thank you and also the sponsors for inviting me to give this talk on behalf of the college SLCIM, Sri Lanka College of Internal Medicine, and its council. I mean, much of what I'm going to say is actually based on the experience of my colleagues who are spread right around the country and who are serving in hospitals, and they do come across lots of issues following this COVID epidemic. And it's a battle. It's a battle, and I think it's part of the battle is in detecting the COVID patients and treating them appropriately. But I see that the bigger battle is to give the standard of care to non-COVID patients. As you rightly pointed out, some of those patients are being missed, and that is a bigger battle. And I think for some reason, we don't see patients with other conditions coming into hospitals or presenting to primary care setups as much as we did earlier. It's almost as if with the COVID breaking out in mid-March, the health system here has been turned on its head. We don't see those patients coming. It cannot be that the patients are not there and that their conditions have gone away. So it seems very much likely that they are not coming to hospitals for some reason. And I think Dr. Aflah alluded to some of the reasons, access issues and all that. But one major issue might be that they don't come out of fear of contracting COVID in the healthcare setups, whether it is in the primary care setup or whether it's in hospitals. They do fear that they could get COVID through these institutions. So one way to get them across to these healthcare setups is to allay those fears, and that is not an easy task. And I feel that one of the main issues here is that they probably are not aware that COVID patients are not being treated everywhere. I mean, COVID patients are being treated in designated COVID centers like the IDH, Mullaria, and few other centers. And in other hospitals, COVID patients are not being treated. Those hospitals just filter out COVID patients. And when they do come in, let's say if a patient comes to the National Hospital, there is a process. If you suspect COVID, then that patient is isolated and the appropriate tests are done. And as soon as the patient is found not to have COVID, the patient is directed to the usual care pathway. And if the patient is detected to have COVID, that patient is transferred to a COVID treatment center. So that process is happening in all hospitals around the country according to Health Ministry guidelines. So I think patients should not fear. They practically cannot contract COVID in the hospitals because there are isolation pathways. And even on medical wards, there are certain isolation areas where we keep patients until certain results are known. And so the message that the public, that patients are safe to come to hospitals has to get through to the public. I think that's one major thing. I see that the main issue here is that when they do come to hospitals, there may also be a fear that they may not be cared for well, that their condition will not be managed very well. Now, we have to make sure that when they do present to hospitals or even primary care setups, that the patients are cared for optimally. And I see three factors we could call them determinants of care. One is staff safety, obviously. The other is giving optimal care to the patient. And then there's a third factor, the resources for diagnostics as well as for personal protective equipment. Now, there's a tight balance between these three, and we have to balance it out. If we concentrate too much on staff safety, then what's going to happen is that patient care will suffer. But on the other hand, if we ignore staff safety completely and go ahead with patient care, there may be infections, occasionally, and that can have an adverse impact in return on patient care. So we must make sure that a tight balance is kept between these factors. Now, one important thing I would like to highlight is that patients who have acute medical conditions have actually not come to hospitals as we expect them to. For example, and it's very dangerous. Now, for example, if there's a young patient, young diabetic with chest pain, he might stay at home for a while, and then he might, when he develops complications, when he develops increasing chest pain, or when he becomes short of breath, he will turn up in hospital. So now the challenge is when that patient comes through in the hospital setup, or for that matter, even in the first contact point and in the primary setup, if the doctor or the healthcare provider feels that this shortness of breath could be due to COVID, obviously there will be an obvious delay in treating this patient. So, I mean, we must use our clinical judgment. Such a patient, a diabetic coming in with chest pain and shortness of breath, probably he has had an MI, acute myocardial infarction, and he is now in heart failure. So we can't doubt the shortness of breath that it is due to some infection like COVID. So we should treat. What will happen if we don't treat this patient? The patient could actually, go into further heart failure, could even die. Even if he does get through, he might end up a cardiac cripple with severe heart failure. So that's going to be a huge issue. The same with a patient who suddenly develops a young hypertensive, let's say, who suddenly develops weakness of one side of the body and he's unable to speak. And if that patient comes through from, let's say, a sort of a lockdown or high transmission COVID area, let's say from Colombo 12 or whatever, then in that situation, if we fear to manage that patient acutely, worrying what his COVID status is, he's going to end up losing his limb and limb function, and maybe he will not be able to speak as well. So those patients under normal circumstances would be rushed to the emergency department, and they would treat them very acutely, maybe even thrombolize those patients. So that may not happen in this COVID era. So that's another thing to guard against. Then common infections, a young girl coming in with high fever and is found to have low blood pressure, tachycardic. Obviously that patient is likely to have dengue and maybe in dengue shock. But if you fear the fever and think that this could be COVID and try to go down that pathway, that patient is not going to make it. So it's very important that we catch those patients. And a very common situation that we see in hospitals now is there's an epidemic of leptospirosis, young farmers, people who are working in the paddy fields. They come in with high fever and with no urine output. Obviously, at any other time, we would just direct them to treatment. As for leptospirosis, dialyze and all that. But if we fear the fever, then we go down another pathway, or the patient will not get prompt treatment. So it's very essential that we treat those patients well. I can mention any number of surgical or obstetric conditions which could be mismanaged. And actually, we have heard of certain cases where patients have not been managed optimally. So that is a point that I would like to sort of draw your attention to. And with the monsoon rains setting in, there'll be lots of dengue patients. And as Aflah said, there'll be exacerbations of COPD, respiratory illnesses. So we do have to take care of those patients. Of course, we have to take precautions, but we have to use our clinical judgment as we have been doing all these years before eruption of this COVID epidemic. Then another point that I would like to sort of draw your attention to is in primary care, because I think quite a few are into primary care in this audience. How could we prevent these comorbid conditions? Now, actually, from exacerbating, that's a very important thing. Now, some of the patients may not be actually even taking drugs. They may not be assessing their blood pressure. They may not be assessing their blood sugar values. So that's a huge issue. And I think as primary care physicians, Probably you may have even registers of those patients, and those patients may be reached, and you could keep a tab on their progress, like checking their, getting them to check their blood pressure with a home blood pressure meter, getting them to check their blood sugar, maybe even do some blood tests, and using technology, give you feedback of their results, and you could manage those patients. At least, may not be optimally, but at least to a certain degree. And one other thing is that even if a patient with comorbidities catches COVID, if that patient's comorbidities are well controlled, the chance of the illness being severe is less. So that is another important message. So people out there who have diabetes, hypertension, they should be as controlled as they possibly can be, so that even in the event of them contracting COVID, the physicians will be able to manage those patients better, and they will have less morbidity and mortality. Another point that I would like to highlight is that some of those patients may not be having access to medication. So in the primary care setup, maybe you could help out. The hospital clinics are all open, and patients are welcome to come in. And of course, when they do come in, we do give them drugs, insulin, all that. So another important message is that which could be sent to the public through the primary care physicians is that hospitals are functioning. So those patients have to go, and it's safe to go. One other point I would sort of try to draw your attention to is trying to make your primary care setup patient-friendly as well. I mean, it's a new situation. This is quite unprecedented, what has happened. It's a new situation. So to make patients feel safe to come to your GP surgery or whatever medical center, I think there can be a few things done. For example, you could maybe use prior appointment process to prevent overcrowding, and when they do come in, you could probably space them out in the waiting area, get them to wear a mask, observe hand hygiene, respiratory etiquette, and also when they do come into your chamber, you could be, using basic personal protective equipment. If you wear a surgical mask, if you wear a pair of gloves, and that should be all right to examine a patient initially. Although telemedicine is helpful, I don't think there is any substitute for a good detailed clinical history and examination. So I think we should not veer away from that basic principle in medicine, because otherwise we are going to miss lots of cases. But of course, you have to be careful with certain procedures, like as Aflah alluded to, nebulization. Maybe that could be an aerosol generating procedure. If you could have a separate area for that, and maybe if you're doing that, wear an N95 mask, then that will protect you. So these guidelines for personal protective equipment, I cannot sort of go into details. All those are in the Health Ministry websites. They are in the form of DG, Director General of Health Service, issued circulars, which are very detailed, and they actually give you a good legal framework as well, legal backup in case there are issues. So you must refer to those, and it's not difficult to get those. If there are contradictions between certain things that you see on websites and certain other information that you get, follow the Ministry of Health circulars. They are very accurate, and they are being updated all the time. And so I think the central point I want to highlight is that I cannot go into each and every case or each and every condition, is that in this COVID era, we run the risk of missing non-COVID patients, and that could lead to severe morbidity and mortality. Just to quote some figures from New York City, in the last 7 weeks, they say that there have been about 24,000 deaths, excess deaths in the New York City alone, and they have only about 14,000 confirmed COVID cases. And they say probably another 5,000 may have been due to COVID. But there are 5,000 deaths which are unaccounted for, and those are actually deaths due to cardiovascular disease, heart ischemic myocardial infarctions, strokes, and maybe even other infections. So now that is a high transmission area. So I mean, at the moment, the disease is in sort of clusters, and most of the clusters are inactive, except for one cluster in the Navy. But even if things sort of worsen and there is high transmission, we have to guard against missing these non-COVID patients more, because it is in that high transmission context or community spread context that more patients can be missed. So my main message is that we should sort of think of all those conditions and the general conditions that we see in hospitals and in primary care setups. I mean, those patients are still there, and they are probably not doing too well at home. So we must try to get them out of their homes and give them the impression that hospital setups, primary care setups are safe for them to come in, and they should come in and get properly treated, because that is the only way we are going to limit non-COVID morbidity and mortality.
Thank you very much, sir. In fact, this was a very descriptive, very practical, and in fact, it clearly you clearly said what's happening inside, and it was very important. I think I didn't really feel like disturbing you just because it was so descriptive and practical. And we may come back to you, sir, within a question time. And in the meantime, I would like to have another look at COVID-19. That is the mental COVID-19 and mental health. Of course, the COVID epidemic is associated with very high morbidity and mortality, and that was like, say, 5 million infected worldwide and more than 300,000 deaths. And there's no proper medication, then there's no vaccine, when it's spreading rapidly, of course, and when the people talk about the second wave, of course, people, they get really frustrated and they are frightened, and of course that may lead to perhaps a panic wave in the community. Now, in fact, this may lead to a panic wave and a very psychotic situation. As a psychiatrist, Dr. Chathurie Suraweera, how would you see this situation, madam? Have you any other? Have you analyzed this situation?
Yes, thank you very much. Good evening, everyone. Usually, when you take a physical illness, only the person who's having the physical illness and those who are closer to the person are going to be affected to a great extent. But in COVID-19, the difference is, yes, the patients are affected and the people closer to them are affected. Not only that, people who are very much distant from them are affected so badly. And not only the physical disease per se, but because of the other behaviors, because of the lockdowns, curfews, and everything that is being put in place to control the illness, a lot of psychological distress is going on. Now, for example, the curfew, the lockdown, there are problems with getting the daily essentials, and then there are financial issues coming up because people are not able to go to work, and also there are issues with getting their salaries, and the daily paid workers, how are they going to run their families? They also have people who are dependent on them, so financial issues are there. And also, we being socially very inclined people, human beings, there has been restrictions that have been put to the social interactions. Now, physical distancing is to be maintained, so the usual social contacts are not being maintained. And also, in certain extreme situations, the wife has not seen the husband, the kids are somewhere else, whereas the parents are somewhere else. So the distancing has taken place. And apart from those factors, there are lots of other psychological issues that are coming up from the uncertainty, because this is a new illness and people don't know much about it. And sometimes even the guidelines keep on changing. And as medical professions, we might be able to understand those things, but sometimes the general public are not able to understand these things. So they might question, how come it is something else that was recommended 2 weeks ago? How come it's changed now? And also the trust, the belongingness, everything is also shaken up here, because you think that everybody else might be carrying COVID-19. So the suspiciousness comes up. So the trust goes away. And also, there is an element of ignorance as well. Like we know, when we started wearing face masks, there were all sorts of issues coming up with the use of face masks. So this ignorance and uncertainty creates anxiety, worry, and also various behaviors like avoidance to the extreme points of not going to work where they are required to work. So those are all the factors that would contribute to the psychological harm or psychological impact of COVID-19. And this has been sort of further aggravated by the fact how the media is reporting. And to the media reporting, most of the time, the general public have sort of got into the habit of being glued to the TV and getting in everything that is being said from different sources like social media, which is adding up to the anxiety that is created by the COVID-19 and the related things that are surrounding it. And this has led to stigma and discrimination. I mean, we are hearing stories about relatives from Navy personnel being marginalized and not getting proper treatment, and sometimes like they've been separated out in their communities. So all these things have contributed remarkably to the psychological well-being of the people. I see this psychological impact on two basic groups, that is the professionals. Because of all these things, we as healthcare professionals have changed our practices. That's why the previous two speakers mentioned that, you know, some of the important other non-COVID cases are being missed because sometimes the patients are not being encouraged to come to hospitals. And on the other hand, the general public, because of the fear that they have developed, they would not come to the services. So those are all psychological things that have come up because of the COVID-19. So just to explain a little bit, how has that changed us, the professionals? Even we have become suspicious. We are sort of thinking as every person who will be coming as a possible patient with COVID-19, and the interventions have got delayed and the histories have become shorter. So there we are somewhat compromising on the healthcare that is given to our patients. On the other hand, general public, while not coming to services, that is one aspect. On the other aspect, they are suffering because they might be having existing medical illnesses and they have no way to get their medications from. The clinics are closed, and also there are certain issues that have come up with because the frontline services have been given priority in certain things. So this has led to some friction as well among the general public and the frontline workers. So
thank you very much. In fact, if I disturb you for a while, in fact, that simply means that COVID, the fear of disease and ill health is not the only reason for this sort of, the virus is not probably the only reason for the psychological effects.
Exactly, because all the factors that I have mentioned earlier, like the curfew, the lockdown, uncertainty, lack of knowledge, all these things have contributed to the psychological distress. So actually speaking, the strain on the mind is more. So why have we been sort of practicing these principles? It could be because we want to protect ourselves. By here, I mean we by like the medical professionals as well as the general public. And also everybody wants to protect their loved ones as well. And also on the other hand, people are feeling socially isolated. And they are feeling all these feelings like guilt, worthlessness, not being able to help. So they are fighting with these emotions as well. And they are being kind of dysfunctional because they are distressed, they're anxious, and they feel as if they don't want to do anything because of this anxiety or depressive symptoms. And also this has led to other unexpected issues, like people are staying at under one roof, and those days they used to go to work and they have other things to do. Now their routine has been disrupted and people are confronted more. So there might be arguments, because there were certain instances that we came across that people are having more arguments and so on, which has ended up in domestic violence and so on. So those are the reactions that most of the time general public will come across. Because our target audience is primary care physicians, let me just brief you as to what to do to these psychological problems that might come because of COVID-19 directly or indirectly. First, the patients would present to you. Most of the time, the patients with pre-existing mental illnesses, they would have been going to their psychiatric clinic, but they might come to you now. What would you do? So you have to check the basic checklist, like, is the patient feeling sad all the time? Is the sleep appetite different now? And is the patient having psychotic symptoms like hearing things when nobody's around, or abnormal beliefs? Because people with existing mental illnesses can relapse because of the stressor per se, and also because of discontinuation of symptoms, because there might not be access to medications. So all of these reasons can lead to people with mental illnesses to relapse. So just please check whether they have got their medications, whether they are having any early signs of relapse, recurrences. So if the patient is on long-term psychotropics, please continue the medications. And also, yes?
No, carry on.
Yeah, so that is what you can do for the patients who are having mental illnesses in the past and who are on medications for the moment. And of course, another issue is psychoactive substances. Actually, now the Health Ministry, together with the College of Psychiatrists, we have made a guideline to the primary care physicians and anybody, the general practitioners, who can use it as a guideline to treat the patients who are having opiate withdrawal, because that has become an issue now. So you can access that in the college website or in the Ministry of Health website, and it's available. So that's an issue. And also, even who are having mental illnesses or general public even might actually present to you with psychological distress. How do you differentiate whether it's anxiety, depression, which requires treatment, or whether it's something that is going to be short lasting and does not really need any major interventions? So I just thought that I would talk to you about that as well, because anxiety, depression, aches and pains and symptoms actually might mimic respiratory symptoms, increased alcohol intake, smoking, fear and worry about your own health or health of your loved ones, worsening of chronic health problems. All these things can present to you, which are actually most of the time manifestations of psychological distress. So just because patient is feeling sad or patient is having sleep issues, which is going to be very common, or having some irritability, you don't have to start the patients on antidepressants. It's only if the patient meets the criteria, like in the case of depression, feeling sad, not wanting to do anything, not interested in pleasurable activities, or sleep disturbances, appetite disturbances, not having energy. If those criteria are met, you can consider starting medications long term or can refer to a psychiatry unit. In the case of anxiety disorders, there would be persistent worry, apprehension, symptoms of sympathetic overactivity, features of muscle tension like aches and pains, neck pains, back pains, again sleep disturbances. Those are the features that would suggest the onset of an anxiety or depression which needs treatment. However, some of these features of distress, like let's say not meeting the above mentioned criteria and just having sleep disturbances or having appetite disturbances, irritability, if they have not been persistent, just lasting for about 1 or 2 weeks, these patients would not actually need to be put on long-term antidepressants. So these patients, just reassurance, explaining what this is all about, explaining that this is normal for them to feel anxious and worried, those simple techniques would do. And also, because now we are most of the time at home, our routines have got disrupted. Most of the people have sort of got into the habit of using social media, TV, which again contributes to this anxiety. So you have to advise them to limit your use of social media. Not only it would make you more anxious and worried, it is also bad in another way because they might end up getting dependent on the screens or video games. So that's why you have to limit all these things and get into a routine. Get into a new routine when you're at home is going to greatly help this. And this in turn would lead to good sleep patterns as well, because if you are glued to the TV, if you are using screens, and if you are sleeping during the daytime and is up during the night time, that's going to end up as a sleep problem. So if you are sticking to the routine, having routine bedtimes, then it's going to make life easier for you.
And madam, just allow me to disturb
Yes.
that question from the audience, and in the meantime, I would like to remind our viewers that you can use the chat option and come to our forward your questions. In fact, this is something on immunity and vaccination. I think I think it should go to Dr. Aflah. And they talk about, so there's a question from the audience. They're asking whether the long-term and short immunity, are we going to achieve immunity or until a vaccine is available? So can you just tell us something about the immunity and vaccination? And sorry to disturb you, madam, I will come back to you. Yes.
In fact, if you take the immunity, as we all discussed, this is altogether a new disease and a lot of scientific research going on. And during this 5.5 months or 6 months time, whatever the evidence there is to say that there is no 100% protective short or long-term immunity with the development of infection. So the WHO has categorically mentioned that even after getting the infection, that one infection maybe in months, there is a possibility of getting another infection. So long-term immunity, we know that the T cells will be playing a big role for development of long-term immunity. So the good news is there are some scientific evidence coming from US that there is a good T cell response for the infection. So we could expect some degree of long-term protection, and that's probably why in Europe they were talking about herd immunity. I don't know how confidently with their data, then they can come out and say that the herd immunity is going to be more protective, like the question came up about the vaccine, and we know that there are more than 200 research or studies going on vaccines for development of vaccine. So some are at most of the vaccines have come up without much routine research data. So some are on production without much valid scientific data, and some the phase 2 trials are also quite a lot of vaccine are on the phase 2 trials, and some have just jumped from phase 1 to phase 3. So like that. So what we can at the moment, like the pathogenesis, like the treatment, and when it comes for immunity, still there is uncertainty and no evidence to say that there is a short-term protection or long-term protection on immunity.
Even after getting the infection, what about the people who got the infection and recovered?
Yeah, this is what I'm saying. After getting the infection, there is no 100% protection to say that they are immune for the second infection.
Okay, then another question from the audience to Dr. Chathurie. Now, of course, during last few couple of days, we saw that people, our army and various other police and other organizations, they are trying to keep the people who are in flats entertained. Are they basically affected with quarantine? And the people who live in the flats, are they grossly or more than the other who are living in other parts of the country? Are they getting more affected by these quarantine measures?
Actually, we so far that, I mean, we don't have any proper research evidence to say that it is so, but obviously from the research in the past, we know people in the quarantine centers are going to be affected, and also these, I mean, we know in these flats also it was a form of quarantining that was taking place. So anybody who is in a restricted area and who is, apart from being placed at one place, which is like restricted in many ways, there are other issues like whether he or she will contract COVID-19, what will happen to them. So all these things are playing a role there. So therefore, generally, what is advised is like, going for pleasurable activities, scheduling the activities, and just not keeping glued to COVID-related activities only, but then having other forms of activities like, let's say, drawing or listening to music. So all these things have been established as useful. So there is a place, but then on the other hand, there are the other issues like, the army going there, there were implications which came up there as well. But sticking to a routine, distracting them, engaging them in other activities, they do have a place.
Okay, thank you very much. Then another question from the audience, I would like to direct it to Dr. Sathischandra. So, is there a difference in death rates during the COVID and the pre-COVID era and the COVID era? Our general statistics, are they changing?
Yeah, well, as far as local statistics are concerned, I think we don't have them right now. And I mean, we must appreciate the fact that there have been very few COVID-related deaths. I think probably about under 10, about 9 so far. We don't have statistics for excess mortality in our hospital systems for the last month or two. Probably those details will emerge a bit later. But I told you about New York, and there has been a huge excess of deaths. So that, I mean, that scenario could come up if community transmission occurs. So far, fortunately, I think there doesn't seem to be evidence of that. The other thing that I would like to sort of stress on as an extension to what Dr. Aflah said is that dependence on herd immunity is probably not a very good idea, because the issue is, for herd immunity to develop, it should spread in the community up to about 60 to 80% of patients should get the infection. The huge issue is if that number of patients get the infection, then there will be about say 50 to 20% of severe cases, and those severe cases most of the time will need ICU care and ventilation, and our health system will simply get overwhelmed by that. And that is exactly what has happened in the US. They underestimated the mortality in those elderly people. In Sri Lanka, so far, the infection has been mostly in the younger population, up to about 70% have been under the age of 60. So we've been lucky that way. I think it's probably due to our cultural system where, you know, our elders stay at home, they don't go out that much. And so they are sheltered, they are protected, which is a good thing. Of course, they will not develop immunity, but then I don't think that we can take the risk of making them immune by getting the infection. We should try and get the vaccine in place. As Aflah said, lots of countries are trying the vaccine. So for the time being, our strategy should be to actively isolate cases, detect cases, then isolate those patients, contact trace around those cases, and limit the spread. And we have achieved that so far. I think there is no community transmission so far. So if we can maintain that, we can prevent our health systems being overwhelmed. Of course, in the meantime, I mean, as a precaution, we should get our health system capacities increased by increasing ICU beds, increasing ventilators, and all that. That backup has to be there, but then we should follow the aggressive strategy followed by South Korea, where they aggressively detected and contact traced patients, and you know they have been successful at limiting the epidemic.
Thank you, sir. And another question from the audience. I think it should go to Dr. Chathurie. What about with sort of obsessive type hand washing? What's happening to your obsessive compulsive hand washing patients? Are they happy, or they go on washing?
Yes, actually, it's like this. Most of the anxiety disorders are prone to get worsened, and also like features like obsessive compulsive symptoms like obsessive hand washing. Yes, in certain patients it has increased, but sometimes, like in patients like obsessive compulsive disorder, not the hand washing, some of the other features have got increased. So both have got increased. I mean, these are, I'm telling with clinical experience, not with scientific data, but we see patients with obsessionally increased hand washing as well as other features getting worse as well.
Okay. Okay. So this is something to do with disinfectant material. So sometimes they say the overuse of disinfectants in clinical setup is harmful. Dr. Aflah, what do you think about it?
Obviously, this question should be put forward to the microbiologist. But now I just today I read an article from just published by WHO about this disinfection, use of disinfectant against COVID in the public places, and they have mentioned that there is no use of those disinfectant to kill the virus. So what happened here is, when we start using more and more disinfectant, we have got a innate immunity, and there can be a problem with apart from the local irritation and the local skin problem, the natural protective mechanism can be also disturbed. So obviously there are no scientific data to show as such, but having said that, now what we are looking here is to look at the preventive measures as much as possible in terms of hand washing and etiquettes, when it comes for cough etiquettes. So all those preventive measures has to be in place, even though we don't have much scientific data to suggest that it can be really harmful.
Thank you very much. Of course, I must say that we have exceeded our allocated time. Then it was very, very interesting. Of course, with the time constraints, I am compelled to say goodbye to all of us. In fact, I would like to thank here our panel of experts, Dr. Harsha Sathischandra, Dr. Aflah Sadikeen and Dr. Chathurie Suraweera. Of course, thank you very much for attending to our workshop. And again, we would like to thank our sponsors here, Dr. Reddy's Laboratories, for hosting this webinar. And again, we would always appreciate our viewers and their kind interest, and of course, hope you are benefited. And again, we would like to thank our technical person and Mr. Anton Thailand. Of course, you helped us a lot. And again, I would like to wish all of you good night and see you with a similar program in future. Thank you very much.
Thank you very much as well.
Thank you. Thank you, Dr.